So, ma'am, I'm going to make a start by introducing you. So, ma'am, I'm going to make a start by introducing you.
One. Amati semua dia ni. Saya amati semua.
I'd be really grateful if all of you could just mute yourself if you haven't already done that. I'd be really grateful if all of you could just mute yourself if you haven't already done that. I'd be really grateful if all of you could just mute yourself if you haven't already done that. I'd be really grateful if all of you could just mute yourself if you haven't already done that. Ma'am, I'm going to make a start by giving introductions for you. Can everybody hear me?
Yes.
Lovely, that's fantastic. So I'd like to introduce our guest speaker today for our course on neonatal ethics. For you, can everybody hear me?
Yes.
Lovely, that's fantastic. So I'd like to introduce our guest speaker today for our course on neonatal ethics. For you, can everybody hear me?
Alok, your voice is echoing twice.
Okay, yep. On neonatal ethics.
And now we can't hear you. Your voice is echoing
Yeah.
twice.
Okay, yep. Ma'am, I'm going to mute myself and I would ask you to start.
Okay. Thank you, Alok, for giving this opportunity. And limits of viability, resuscitation, counseling, hitches, what we face here, I'm going to talk about it. We are talking of big dreams for small miracles. And Alok had asked me to highlight on the differences what we have here as compared to the Western world, and how do we end up in certain decisions. So I would take in that way. So objectives are to provide a review of standard practice in dealing with babies at the limits of viability in our setup and around us, and how do we decide which babies to resuscitate. Clinical difficulties associated with these situations, survival as per our experience and the literature, and how do we counsel the parents, which is very important, I would say, to formulate the management plan. How do we take them together for especially the babies who are at the threshold of viability, and some of the cultural insurance issues which we face, and what do we do if we have to stop delivery room resuscitation. So call came to you from your obstetric colleague. A mom came in labor pain, bleeding at 23 weeks of gestation. What would you tell her? What would you tell the family? What would you say? What's your age of viability? That's what we are going to discuss, and I'm sure at the end of the talk we'll be more clear. So our approach usually is risk-based, and we do assess the risk for the babies, and then we counsel the parents according to that. We agree to a point where we communicate together a management plan. So usually the assessment is usually the gestational based risk assessment is the most important one. But we do take care of other things as well, which we will talk about it. And the main thing about gestational based risk assessment is mortality and impairment, which we are combining together. And then the modified risk assessment. So what exactly is this peri-viable period? It's quite challenging to define the level of maturity below which survival and neurodevelopmental outcome is quite unlikely. And it's based on two things: survival, which is quite objective, and neurodevelopmental outcome, I would say, which affects adversely the quality of life, is quite subjective. And I find it quite difficult to define sometimes. And if you see lots of studies, they take different things. So we try to define a gray zone or a peri-viable period, discuss, negotiate, and sometimes we do compromise. So the limits of viability, how small is too small? So usually we base our decision on this chart. Like if a baby is, we know who's going to be born, is mature enough to have a reasonable chance of good outcome, definitely we will go for an aggressive care. And if we say it is too immature to have any reasonable chance of survival without deficits, it will be a comfort care. But here is the problem where the gray zone starts, and ability to correctly assess gestational age before and most importantly, I would say after the delivery matters. And then we need to perform a meaningful prenatal consultation with obstetrician and the family regarding this gray zone thing. Now, when we have gestational based risk assessment, first is the mortality and then is the neurodevelopmental outcome. So looking at the mortality, I wonder when I was doing my medical school and I knew only two things. Preterm means who's less than 37 weeker and term means more than 37 weeker. And over a period of time, different more terminologies were introduced, and preterms were subdivided into late preterms 34 to 36 weeks, moderately preterm 32 to 34, and very preterm 28 to 32 weeks, and extremely preterms less than 28 weeks. And I'm sure another designation is going to come for the babies who are less than 25 weeker, 24 weeker. Less than 25 for sure. So what is viability? At which there is a 50% or without here. And under current conditions, viability in developed countries is around 22 to 24 weeks, I should say. And if you look at the preterm deliveries, they are around the world. If you see, 5 to 18% are born preterm, and out of those, more than 80% are 32 to 37 weeks, which usually survive well with essential newborn care. But we are more focusing on less than 28 weeks gestation. And that's what is peri-viable birth, which is different in different countries. And there was an obstetric consensus guideline which came in 2017, which they were talking in length about the evidence regarding the spectrum of outcomes for infants born in this peri-viable period. And recent UK data talked about it, that 40% of the babies who are born 23 to 23 plus 6 weeks who are only surviving when they received an active treatment after birth. And if you see different data which were released time to time, the survival rates were different. And if you see here in 2015, 22 weeker hardly survived and 23 weeker were surviving less than 20%. And year later, 2 years later, the survival had improved. And in one of the centers, which is Japanese, 22 weeker survival was almost 40%. And the rest of the countries were again less than 10%. And then another year later, when we combined, almost it looked to be similar. There are countries which are having a good survival. Again, Japan is ahead of all. And then is the Taiwan and the Sweden data is quite impressive as well. And if we talk in numbers, then you will see that there is a lot of variation if you look at, but these are a little bit older, Epicure, Express, and these data are big, robust data, and they, if you see, the 23-weeker survival is varying from 11% in one place to 54% in others, and similar is the issue with the 24-weeker and 25-weeker. And no one here is talking about 22 weeks. And the Victorian cohort Australians in 2014-16 said that less than 23 weeks have virtually no chance of intact survival, and they were more focusing on 25 weeks and above. And NICHD data, they also talked about that survival, less than 500 gram babies have no virtually chance of intact survival. And if they survive, they would be surviving with a profound impairment of like non-ambulatory CP, mental retarded, severe visual or hearing loss, or a combination of above. And they were more focusing into more than 500 to 600 grams babies. And this data of Vermont-Oxford network, they saw babies between 400 to 500 gram. And 50%, 4,000 babies were there, and 50% died in the delivery room. Another 50% died in the NICU, and around 690 babies survived. And they, for the first time, they were talking about that the success of the delivery room depended, and the NICU admissions depended on other factors as well, like female gender, cesarean, SGA, prenatal steroids. So what we can see from this slide is that things which were there in 1980s is not in 90s, and then early 90s, mid 90s, late 90s, there was a improvement, and same is early 2000s and mid 2000s. So we can see that 22 weekers are surviving more and more, and 23 weekers are surviving more. Each gestation is showing an improvement as the time passes. And why is it happening? Because of the fact that we are itself learning a lot about these small babies, and we have a medical progress in the regional cohort, starting from the CPAP to the exogenous surfactant, antenatal steroids, and avoiding the postnatal steroids, targeting oxygen therapy, and many more are coming day after day. And I'm surprised we still do not know much about these preemies, and every day we come out with something new which would help our babies, like delayed cord clamping, magnesium sulfate, and so on and so forth. We will talk about it. But what I mean is that, you know, should not fix our self and saying, no, the viability is only this much, because everything is improving, and so would be the improvement in our survival of these small babies. And in North America, again, example, in 1940s, they were saying 50% of survival was at 32 to 33 weeks. In 60s, it went up to 30, 31. In 80s, 26 to 27, 2000, 24 weeks. And 2020, they're talking about 22 weeks as well. So we have to be going further, improving ourselves. What does the ACOG guidelines say? So this is very interesting slide, where the ACOG, of course, says less than 21 weeks, 22 weeks, nothing is recommended. To 22 weeker, they said that you can consider to resuscitate, but nothing else is recommended. So they don't talk about steroid, they don't talk about tocolysis, magnesium sulfate, intrapartum antibiotic for GBS, and cesarean deliveries. And if you see, even for 23 weeker, they are saying you can consider. So they're not recommending. And recommendation comes only at 24 weeks. So this is what the latest ACOG has to tell. Now, what is our land law telling us? So the standards for obstetric and neonatal services by DHA, the Dubai Health Authority, came in 2018, and they said that stillbirth means who is more than 500 grams and who is more than 24 weeks. So that means they gave the viability for 24 weeks and 500 gram, and they counted neonatal death in first 28 days of completed days of life. So because of that, if you see the things comes in headline, these are my babies who was saved in 2016, 23 weeker, 530 grammer. And so it comes as a big headline, and this went up to the India NDTV as well. And then there were more smaller babies under my unit which were saved, and which is again and again coming in the headlines. And then there were other small babies who were being saved at different units in the Dubai. They were also coming up as a big success stories in the newspapers, and same is true for Abu Dhabi. So if you see when they're coming in the newspaper, that means it's a big thing. It's not like it's, and these are mostly 23, 24 weeker babies. They are not talking about 22 weeks. And last year, 2019, this data of Latifa Hospital, which is one of the biggest unit catering to these neonatal ICU, they are around 60, 70 beds. And they have 4,000 deliveries in a year, and in them 11 babies were born below 500 grams. So that came as a big news. And the Cornish is another unit in Abu Dhabi where they have their 80 bedded NICU, and I could get their data. And none of the babies born 22 weeks could be saved. 23 weeker, they had 21% survival, and 24 weeker 51% survival, and 25 weeker 88% survival, which is equal to or little better than the survival of Epicure, but that is 2006, and we are in 2020, so I'm sure it's going to improve. So that's the little bit, logistics and little bit of infrastructure, manpower, all these count when we actually save these small babies. So all these data, if you combine, what does it show? It shows that a preterm neonate who's less than 500 grams, less than 23 weeks are too immature to survive with current technology, and provision of care other than comfort care is unreasonable even if parents wish to have everything done for the neonate. Mainly you should focus on more than 25 week or more than 600 grams because their survival rate is much better. I don't agree to this, and I was very thrilled when I heard this EOA talk a month back, where they showed their survival of 22 weeks around 58%, and 23, 74%, and 24 week at 25%, which was very heartening. And their long-term data was also shared, which was very good. So when they can do it, why can't we do it? And for that, I would like to show this slide. It is very good. One thing I like about UAE is that when they go achieve something and they take everyone together, and that's how you can achieve it. It comes as a big thing. And so this was the Mars mission, which just happened a few days back. And this is their first picture, which they had shown sent from the space, which shows these 3 volcanoes. Why I'm sharing this is because I feel that we can achieve through excellence. So there is no substitute for a total preparation and complete dedication for space, and so is for the NICU. And I, as such, believe that we should not be tolerating any carelessness or indifference in our workplace. Teamwork should be our main motive, and if you are respecting and utilizing the ability of the others, realizing that we work towards a common goal for success, we will succeed. So we should, in the end, we should say that we did try and fail, not that we never tried. So why will you not save? Finance to allow them to save is not available. Fetus does not have right to live, no medical legal support for them, and or the expertise is not there. Worried about the neurodevelopment outcome? When you don't know what's going to happen, why are you worried? And hence, I would say that, okay, let's look at the long-term outcome and then talk about it. So if you look at the long-term outcome over a period of time, it is improved. And as we can see that the babies who are born quite preterm, like 22-weeker, their moderate to severe disability is much higher than baby who's born at 23 weeks and then compare to 24 and 25 weeks. So definitely we know that the babies who are born earlier may have more moderate to severe disability, and then this continue to be true when they're at 4 to 8 years of age, where 22-weeker rate of severe disability was 31% and moderate to severe was 43, as compared to 23-weeker who were much less severe disabled than 22-weeker. But if you see here, 24-weeker is more than 23 weeks. So there are certain more things which I want to highlight. Not only the gestation is not the only thing, and there are other things also which play a role, and we should understand that. And another study which looked into the survivors without major morbidity, less than 26 weeks, almost they were 30%. And hence, if we combine all of them, we can say that if a baby is born between 22 to 22 plus 6 weeks, 1 in 3 of them would have a severe impairment. And between 23 to 23 plus 6 weeks, 1 in 4 would have severe impairment. 24 to 25, 1 in 7, and 26 to 26 plus 6, 1 in 10 survivors may have severe impairment. This is from the data what we saw. But then another study which was published in JAMA by Saigal et al., they looked into these babies who became adult in mid-30s. And what they found that they compared ELBWs versus full term. And they found that they had similar levels of education. There was no significant difference in the rate of employment or income, no difference in living arrangements and reproductivity. There was little bit higher rates of psychiatric problem in the form of depression and anxiety, and there was a lower risk of taking behaviors. So what I see that they are quite productive members of the society even when they grow up. So really, is the disability rate increasing? I would say no, because the proportion of the extremely low gestational age surviving without disability are actually increasing. More of them are being surviving, and that's why overall we see they are more disabled, but percentage proportion wise it's getting better. And also, as we will learn how to take care of these babies, it's gonna go better and better. So when we combine both now, mortality and the neurodevelopment outcome, then how do we come to any conclusion? What can we do with these babies? So if we say the risk or high likelihood of mortality or severe neurodevelopmental outcome is going to be there, which can happen in infants who are born at 22 weeks, irrespective of the additional risk factors. Infants at 24 weeks with risk factors or estimated weight of 350 grams, then you might consider to give palliative care in these babies. Moderate to high likelihood of mortality or moderate to severe neurodevelopmental outcome. These are the babies which are 23 to 24 weeker with irrespective of additional risk factors, and 24 to 25 weeker with risk factors. So here you can decide on intensive care or palliative care depending on the other things. And low likelihood of mortality, definitely these babies would require to be given intensive care. And these are the babies 25 weeks without additional risk factors, 24 weeks without antenatal risk factors and getting an antenatal steroids, and are born in a nice tertiary level centers. So what do people do when they get these babies? Let's see who resuscitate and who doesn't. So this was a neonatologist survey for you from US. And if you see, less than 4% said that they will be resuscitating baby at 23 weeks. And most of them would defer to the parents. They will ask the parents and take their choice. And if it is 25 weeker, they are not taking that much of parental thing, and 90% of them would be resuscitating. And some say I would withhold my resuscitation decision until I saw how the infant looked. Some say that I would resuscitate initially, but I might reconsider after I saw how the infant responded. I think that would be a better thing, and that's how we do it here, that we resuscitate initially and then reconsider what to do. So now can I define peri-viable gray zone better now after all this discussions? So I would say that peri-viable is between 22 to 23 weeks, 400 to 500 grams. And we all know that survival and the long-term outcomes are overall poor but difficult to predict. And the line between patient autonomy and medical futility is blurred in this gray zone. So we will be talking to the parents with that. And hence comes the antenatal counseling. And main thing what I talk is the gestational age given to us antenatally is right or not? And I would say that go and reassess yourself during the delivery, and the neonatologist should be doing that. And the parents' wish in the gray zone should be honored unless they do not represent child's best interest. If there is an uncertainty at any level, provide clinical care and reassess the patient's response. So when we talk about the gestational age, I'm sure that, if you look at the ultrasounds, we all know that the reliability of the ultrasounds is not that great, and accuracy of the ultrasound for the gestation varies from first, second, and third trimester. And if we say that we have done everything right, still there would be a variation of 7 to 10 days and that's the main thing, window of the limits of viability. And also it depends on how many ultrasounds are being done at a given time. And different people are doing at different, some of them are doing 1.5 per pregnancy, some of them are doing 2.7. And then if it is high risk, they are doing 4.2. What we do here is 3 to 4 ultrasounds are done per pregnancy. And so it's quite reliable, but still we should be, whenever there is a peri-viable state, must go and see, because you're not sure. And then modified risk assessment is very important, because this is not just the gestational age which matters. The sex of the baby, multiple pregnancy, congenital anomalies, poor fetal growth, prolonged pre-labor rupture of membranes before 24 weeks of gestation, and clinical evidence of chorioamnitis, where the baby is getting delivered, is it in the high center or not, also matters. So if we see the obstetricians can very nicely define that the next baby is going to be preterm or not, I would say no, because prior preterm births, only 21% would be next preterm. And 34% were previous term babies were born preterm. First pregnancy has a higher chance, and prior antibiotic received, there are more chances of getting preterm deliveries. And then the causes also matter, because most of the causes, the main cause is the PPRM, and then is the preterm labor. Then comes the hemorrhage and stillbirth, and then the multiple gestation is another cause. So because cause also will be an important factor when we will know the outcomes of these babies. Now, I want to highlight again and again, gestational age alone is not the sole predictor. If you see here, 24 weeker at 7 to 10 years of outcome, no impairment was less than the 20 to 23 weeker here. So there were more babies at 22 to 23 weeks, babies were having no impairment. So that means there are certain other things which also matter. And the other things are major congenital anomalies, severe IUGR defined as less than 2 standard deviation, intrauterine drug exposure, fetal distress defined as spot pH less than 7.1, cardiorespiratory neurological depression at delivery defined as 5 minutes FCAR less than 4, congenital sepsis defined as blood culture taken after birth being positive, chronic intrauterine infection where the culture or serology in baby would tell us, congenital anemia when hematocrit is less than 35%. So these are important factors. And one of the study showed that the babies between 400 to 500 gram in gestation, 23 weeks plus minus 2, the mortality was more in first 24 hours if they had chorioamnionitis, placental abruption, and multiple birth. Mortality was less if they were born at tertiary level 3 hospitals. Tocolysis was given, antenatal steroids were given, cesarean sections were done. And hence we have to be talking about it, and fetal compromise is very important, and that's the role where when we go and see how's the baby when the baby is born. So the baby is born with a fetal compromise and is 23 weeker will be more chance of less survival than a baby who is not compromised. And this difference is not that great if the baby is 24 to 25 weeker. So smaller the baby, more chances of it not to survive if the fetal compromise is there. So we should take that into consideration. Also, if you look at the weight, if smaller weight is there and the baby is also fetal compromised, the mortality is more, chance of survival is much less than when the weight is more. And if there is no fetal compromise, the survival is better. And if the same baby, if fetal compromise but receives steroids, the chances of survival is better. And if no steroids are given, the chances of survival is less, especially if more fetal compromise is happening. So this is important. However, when we looked into the APGAR and then looked into how the babies later performed, it didn't have a very good relationship. I think this is because the way we are doing ours, it was retrospectively done and we might not be doing it right. And time for APGAR to be out of the box, I would say, even for asphyxia, for that matter. So problems with predicting long-term outcomes with risk looking at the viability age is multiple, as I told, those risk factors. Plus also when the baby is born, so the babies who are born and they have severe brain injury or they have BPD, they have neck, they received steroids, they were male, definitely those babies will have a bad outcome. And later on, this is important also, that maternal education and home environment which is given to these babies also have an important role for the long-term neurodevelopmental outcome. So this is also to be seen when we talk to the parents. So combining everything, 22 to 23 weeks will have a chance of higher, especially in our setup where whatever we have, that's how we see. And 22 to 23 weeks with the favorable risk factors are considered to be high risk, and most of the babies more than 23 weeks are moderate risk of survival and disability. So why to debate? As I said, gestational age is itself not a good predictor of neurodevelopmental outcome. UAE, we talked about, okay, the law said 24 weeks and above, but we are saving babies 23 weeker, 22 weeker, and less than 500 grams. So this doesn't hold true still. Disability, so what? Like, because we cannot take, the right of the baby. And debate should be to convince my colleagues that it's not gestational age, but something else which is responsible, and we have to look into that something else. So now can I make a decision at the gray zone with confidence? I think little bit yes. Here 22 to 23 weeks, birth weight between 400 to 500 gram, and any fetal compromise detected before delivery, we say it comes into the peri-viable age. And we as a neonatologist should be going to the delivery room and then assessing and then taking the decision. Before that, we should be talking to the parents, explain the complexity of the situation and our limits to decide a definitive course of action before the delivery. So how do we do that? How do we counsel our parents here? So what do we do? I'm going to highlight that. So the obs and gynae, from a high-risk obs and gynae clinic, the parents come to us. Sometimes if time permits, first I will talk to them and then we can combine talk with gynecologist team. We If there are certain high-risk things, we even the genetic thing, pediatric surgeon, metabolic consultants also may chip in, and neonatologists and the pediatricians, we talk together along with the fetal medicine. So these are the team which is going to talk. We take them, we talk to them, we show them our unit, and we show our data. We make them to meet. We have videos of the mothers whose babies are surviving, so we tend them to see those videos. We start with some of the data of Western countries. This is what they are doing. Like this is a Canadian society which their data is showing survival and babies who receive palliative care. So we show those, and then we talk about our data. So we should know what patient wants. So I know that the patient wants clarity, honesty. They want us that we should be listening to them, should have a positive approach, supportive team. They need a clear treatment plan and an expected outcome. So we try to greet the family with smiles, sit down and talk, take them to we have our counseling room, not hurry-burry on the corridor or in the clinic. This problem comes when Alok told me to highlight the problems. This is the problem, like we need to talk to in parents' language, and unfortunately I have not yet learned a proper Arabic language. So I can understand a bit, but fluent talking is not there. So I always make it a point that one of the registrar who is Arabic speaking is with us to understand and talk to them in their language. We end up in relevant discussions and try to engage family in the discussion, try to keep repeating the key messages in between. And we have prepared pamphlets of our unit with data. We have prepared videos of our nurses, of the mothers, as I said, and of me, which we share with them. And this is how we go into the counseling room and counsel. And I try not to appear in hurry and not to use too much of medical terms, look at our watch frequently, seeing the mobile and WhatsApp frequently, talk with the hand or a door or foot outside. No, not to do that. And I don't try to ignore the concerns mentioned by parents. We all know that parents are Googled already. So the Google is a real problem for all of us, I know. And so we have to be prepared for that and not like ignore the concerns mentioned by the parents. So this is our data, and we try to show this data that what is our last 3 year survival: 23 weeks, 70%, 24 to 26 weeks, 80%, 26 to 28 weeks, 90%, 28 to 30, 95, and more than 30 weeks, almost 100% have survived. And this is important because they want to ask how many days our baby is going to stay in the hospital. So smaller the baby, 23 weeker, it may stay, because last baby which we discharged, who had a lot of problem, was staying with us for around 3.5 months, 4 months, I think. So 100 to 160 days, 24 weeker, 100 to 140 days, 25 weeks, 100 to 120 days. I actually, whatever is the timing, I make it 20% extra so that the parents have, they are more relaxed if the baby is staying for longer. And then 26 week is 80 to 100 days, 27, 60 to 80, 28 weeker stays usually 50 to 70 days. 29 weeker stays usually 40 to 50, and 30 to 32 weeker 20 to 40 days, and 30 to 34 weeker is not more than 10 to 20 days. Sometimes 34 weeker is only for 1 or 2 days, 3 days till they are actually feeding well. And the invasive and non-invasive support is almost 100% required by less than 28 weekers. 28 to 30 weekers, 60 to 80% required support, and more than 30 weekers, very less, 30 to 50% only would require the invasive and non-invasive support. And the duration also would be more for our babies who are 23 weeker, and sometimes it crosses even 56 days when they are on CPAP for a longer time. And 24 to 26 weeker is lesser, 20 to 50 days, 26 to 28 weeker, 14 to 42 days, and 28 to 30 weeks is 7 to 21 days, and more than 30 weeks, not more than 5 to 10 days. And then IVH, we have our data is 10 to 15% for 23 weeker, 24 to 26 weeker is 8 to 15, 26 to 28 weeker is 5 to 10, and 28 to 30, 1 to 5, and more than 30 is no IVH. Similar, our PVL we have much less than the IVH, and they are varying from 1 to 8% maximum. And ROP is also very less in our settings, and but we do have to tell about the ROP and the treatment involved. And the neck is also quite less in our unit. It is 1 to 2% of neck is there. Bigger babies, we have not seen neck more than 28 weeker. And the long-term outcome was quite good for those babies who survived in our unit. 80% for 23 weeker, 85% they were normal at 18 months, or 24 weeker, 25 weeker 90, and 26 weeker 95% intact survival. I use this chart to give them a number, like I just put it, and I feel it quite handy after showing our data. Just put, this is an NICHD chart, which is easily available and free in the net. You put gestation, you put the weight, the sex, single or multiple, and steroids received or not. And then, because we know that factors improving survival and outcome are gestational age, weight, and female sex, steroids, and singleton birth. And then once we put, like I gave you example, this is what I have already put, and then it comes that how much is going to be survival overall, and how much would be survival if we ventilate these babies, how much would be survival without profound neurodevelopmental outcome, and with moderate to severe impairment, death and combined outcome. So this comes as a number, and we can show and talk to the parents, and I use it, and I find it quite similar to what comes in our unit. And it also talks about lungs and breathing problems, gut problem, nutrition problem, bleeding in brain, risk of infection, long-term issues. So all that comes in one go, and we can talk with clarity with the parents. And so once it happens, we have done the appropriate counseling, we have reached to certain conclusions, and we know which, where do we stand, and what are the parents' wishes in this, and we honor those wishes. And we always tell them that we will reassess when we go there. So decisions would be like either palliative or comfort care with no neonatal team attendance at the delivery, or we attend the delivery and then decide whether we are going to go for a palliative or a comfort care. So this is a very busy kind of slide, but it is very, very beneficial. So if a baby is less than 400 gram or less than 22 weeks anticipated, we do not resuscitate or initiate comfort care. We initiate comfort care measures. And if it is a more than 500 gram and 23 weeks and above, we initiate resuscitation, and clinical course will dictate the management. However, we say this is our gray zone where the baby is 22 to 23 week, 400 to 500 grams, where we will assess the heart rate, and if it is low or absent, we will not do any resuscitation. If the heart rate is present more than 40 to 50, we do start resuscitating. And if the heart rate improves, we would do some CPR, and if there is a poor response, again we will discontinue the intervention and we'll initiate the comfort care. However, if we get a good response, we do, these are small babies, they take time to get temperature maintained and all that stuff. So these are the babies which we give surfactant there, because it will take time for us to take the baby to the NICU. The other babies who are more than 23 week, 500 gram, we do not give surfactant in the delivery room. Because I've seen that smaller babies and those who require resuscitation, whatever we do when we take them to the NICU, their temperature is less, and I just don't like the babies being hypothermic when we reach to the NICU. And hence what I said is this, that 23 to 26 weeks, we do have active resuscitation. If it is 23 weeks and above, our whole team would be there and we would give the full-fledged thing. 22 to 22 plus 6, we will still be there and we will decide when how the baby is after the baby is out. So once we decide that we are going to do palliative comfort neonatal management, what we do that we should be there to provide a brief assessment of the baby's condition at birth and to support the gynecologist and the family. We do not give respiratory support. We offer the parents to hold and spend as much time as they want with the baby in a quiet and private location. We counsel them that the baby may have brief reflex, because I remember once we had a 22-weeker twins delivery, and later on we went into litigation because the baby had a brief reflex movement, a little bit signs of life after birth, and they said, oh, they did not resuscitate our baby properly and they left our baby to die. So we have to counsel that these reflexes might be there, and they who are receiving the comfort zone may 60 minutes may be needed for us to see them. So this is important. So these already we talked about that what we do, and I just want to highlight that again, same thing. We should see there and then decide whether our gestational age is okay or not, and then talk to the parents, clearly documenting. I go and whenever I'm doing counseling, antenatal counseling, I'm going and documenting in the mother's file whatever I have talked to the parents, and take their signature, my signature, and one of the witness signature, that all of us are in same page, and then the gynecologist signature. Now, once we have decided and we are getting ready for the delivery, I have decided that I'm going to resuscitate. What I do, we have lots of clinics, so we tell them, the other gynecologists, please transfer the patient to our hospital early on and not in the last minute. We administer antenatal steroids, tocolytics to gain time for the steroid effect, antibiotic if there is PPRM, and willingness to perform cesarean delivery once threshold of viability has been reached, and administration of magnesium sulfate. So how do we do? I'm sure the baby tells I'm likely to arrive early, so help my lungs to mature with your drugs. So antenatal steroid is a real must. And we all agree that more than 24-weeker, it's written in the literature, and everyone agrees to that you should give antenatal steroids. But what happens to babies who are 20 to 23 weeker, there is less certainty. And so I would say we have to start, as I said, we have to go to Mars now. So we have to do something different to achieve that. And the difference will start from the antenatal period, where we have to tell our obstetric colleagues that these are the data, some of the data which say that if you give antenatal steroid at 22 to 25 weeks, it did reduce the death and severe IVH and neurodevelopmental outcome at 18 to 22 months, and increase the survival from 18% to 39% at 22 weeks. So when it helped for more than 24 weeks in all these things, RDS, NEC, IVH, mortality, why it's not going to happen that it's going to help our babies at 22 weeks. So if we decide that it is peri-viable, and we will go and see once the baby is delivered, we will tell the obstetric colleague to give antenatal steroid to these moms. Then whether we should do cesarean or we should not do cesarean, between 24 to 27 weeks, if the baby is born breech, it is seen that it is, if you do cesarean, there will be less death, and death or asphyxia combined would be less. So this should be talked about. And so data actually doesn't support routine cesarean to do for improving the perinatal mortality or neurological outcome in early preterm infants. However, it does benefit in a growth restricted infant regardless of the presentation, and if especially breech, then survival advantage is always there. And so vaginal delivery, you cannot tell your colleague, because then whatever chance we have for those babies to be benefited will be lost. So that's what we do here. And we anticipate and plan, because once the mother is coming, it can deliver anytime. So that's not under my control. Baby is telling us, so I may arrive early. Be ready with your skills and adequate setup. And so be prepared. And they are blessed with the nature's power. I'm at par with other newborns of animal kingdom. I am unique. Be ready to welcome me. So you should be having all the equipments much ready before time. So we have a tiny baby system where we all know that whenever these small babies are going to come to our unit, survival depends not only on the decision to resuscitate, but also in many other factors, as I already talked about. There is a metaphysical differences which matters, and there is a galaxy of system which is required to dedicate to the structure, culture for these extreme preemies. And all the babies who are less than 26 weeks, we don't have different NICUs. We don't have different like rooms, but we have infants space, like we dedicate a space separate for these small babies, separate nursing staff. We have like a senior staff, medium level staff, and a low staff. So we have a senior level staff designated for these babies, and also because we want to keep the area warm, so we have a separate location integrated with labor room and OT. Dedicated team of neonatal NRP trained nurses, registrars, consultants, and pharmacists chip in. And in-house ABG machine which has electrolyte and hemoglobin measurements, portable X-rays, portable ultrasounds, and echo machines are important. Always we run a simulation before any premature or any high-risk delivery is there, because I have seen whenever we do that, we end up in a minimum mistake. Otherwise, all are in mess. So if time permits, we do simulation before every delivery, high-risk delivery. And in between, we keep on running some simulations so that team is at par with each other and there's a good coordination going on. So we ask for additional manpower. Obviously, everyone has a scarcity of the manpower. We do briefing, designate the roles, ask someone to please help our gynae colleagues to bring up the temperature of the labor room. We take with us polyethylene, plastic wrap, cap, thermal mattress. For these babies, I have seen that we do need these thermal mattresses along with the plastic wrap, the babies who are born before 24 weeks. Servo control warmer, we preheat. Air oxygen blender is a must, pulse oximeter, appropriate size oximeter sensors, electronic cardiac monitors, ECG with chest and limb leads. T-piece resuscitator we are always using in the delivery room and also in the NICU, which provides us PEEP and CPAP and PIP. We take with us preterm size mask, laryngoscope of different sizes, and ET tube of different sizes. Surfactant we take because, as I said, if baby is 23 weeks and smaller, they take a lot of time to, and I don't worry them and bring them hypothermic. And pre-warm transport incubator is always ready. Then what do we do in the delivery room? We, as I said, it's a tertiary care setting. We try to delay the cord clamping, which is always not being possible. I'll talk about it in a minute. The oxygenation, I will talk about it. T-piece we are always use right off, and delivery room CPAP we use. And as I said, surfactant only if we are anticipating transport later, and cling wrap we are using. So this delayed cord clamping, the baby says, let me stabilize and allow me at least 30 seconds before you cut my first connection with my mother. This usually we allow if the baby is not to limp. And we all want delayed cord clamping, and we all know that intact cord resuscitation has challenges of shortcut, maintaining sterility there, inadequate access to personnel, difficulty in temperature maintenance and monitoring. So fortunately, this trolley is available now in UAE, and we are going to go and purchase this trolley for our unit so as to have a delayed cord clamping easily done along with the resuscitation. First golden minute and room air resuscitation, what do we do? Baby is asking for help and wants that this first 60 seconds you should do without harming. So as I said, we use T-piece resuscitator, and if at all we used to need an ambu bag, it should be with a CPAP and a manometer, which will provide us to show us how much PIP are we giving to the baby. And we have these charts in place in all the delivery rooms and in all the OTs, where we are minimizing the hyperoxia and hypoxia in the delivery room. We use the NRP algorithm. For less than 24 week, I start 40%, and for more than 24 week, we start 30%, and we titrate accordingly. And we use TPs, as I said. And mostly we don't give surfactant in delivery room unless we are thinking we are going to take longer. Now, this peri-viable lung is very important. They are born without surfactant. They are born without alveoli. We should realize this. So they are not similar to a baby who is 26 weaker. So this is different. And hence, we are going to not allow it to be collapsing. If the baby is breathing, which is happening at 24, 25 weaker, or even 23 weaker, we prefer CPAP. If in a smaller baby, we might need to intubate, but for bigger babies, 23 and above, we would say that do not trouble me with your ventilators, please. If I don't require it, don't put it on me. And we give surfactant whenever baby is intubated, or if not intubated and we are giving NIPPV and requiring FiO2 of more than 30%. If baby is on NIPPV or CPAP, we use LISA, and we have LISA catheters in place. We used to use orogastric tube when we didn't have LISA catheters, and we were using even umbilical catheters before that. I will talk about it, cultural issues. Whenever we are able to, we give Pyrosurf in higher dose, 2.5 ml per kg, and we repeat at a lower dose, 1.25 ml per kg after 2 to 4 hours if required. And later when the baby slumps, and so many times with these tiny babies, less than 24 weeks, we have seen that on day 6, they have another slump when the surfactant is gone, which we have given, and the new is still not coming up, or pneumonia, infection, PDA is eaten up this surfactant. So we do not hesitate to give another dose of surfactant. And it's shown that whenever you are giving more doses of surfactant, we have a better outcome whenever it's done. So it reduces the risk of this post-surfactant slump. This is important, what we do. NICU, what we do is we try to avoid anti-electrotrauma. We always use volume guarantee if we have to intubate the baby, and we use assist control or SIPPV. We keep a very low threshold for high frequency, and we use HFOV. Whenever we reach PIP more than 20, we put the baby on high frequency oscillation. For babies who are more than 24 weaker, we extubate early, and we avoid intubation in the first place in the delivery room, give surfactant by LISA. So we have a policy to keep the tube off. For babies who are less than 24 weeks, also we try to extubate early, but only when they are ready. We do not push them off, because we have seen that failed extubation in the first week of life in this population is significantly associated with increased death before discharge. And it is quite significant, 28% versus 6%. So anybody who is less than 23 weaker, 24 weaker, 23, 22 weaker, they will be remaining on intubation, ventilation for a longer period. And we need to minimize multiple failure attempts. We extubate to NIPPV, and I don't use for less than 24 weaker CPAP initially. I put them on NIPPV. And I agree to Dr. Ramanathan that if you compare NIPPV with CPAP, there is a decreased rate of extubation failure, lower rate of clinical BPD, lower rate of physiological BPD. So we put on NIPPV, and then we switch to the CPAP once they are ready. The other thing which we keep is in our NICU is within 1 hour of NICU admission, following has to be finished: insertion of umbilical lines, surfactant, and TPN orders. We start EBM within first 12 hours, and we are very aggressive on that. If the baby is stable, we go 30 to 40 ml per kg per day. We give caffeine early within 6 hours, and we do ultrasound brain for IVH on day 1, 3, 7, 28, and 4 weeks. We do routinely functional echo to see what's happening to our PDAs, but I'm very, very conservative in PDA treatment. We do aggressive phototherapy, and I listen to baby when baby says, I want my mom's milk only. All the animals are getting that. Why should I not get it? It's my birthright, and we should respect it. So we should. My body is compatible only with my mother's milk. So give me fast. So we have seen that breastfeeding initially and giving EBM does save our babies from many things, from sepsis, from neck, and even BPD. And we try to counsel our parents to express the milk as early as possible if they are fine. And here we don't have milk bank, and culturally the issues are there to use other mother's milk. But sometimes when we talk about and give them importance of the breast milk, some of the mothers I've seen, they bring their relatives' milk, though, and we do take consent from them, because we are not checking that milk with the other, like how they are rigorously checked for CMV, HIV, hepatitis, and all. But taking the consent, we do give the milk which are brought by the parents of their own relatives. So my baby, I have come from a very clean environment, and so please keep me clean. I'm sure babies mostly are not infected. Touch me clean, respect my clean status. This we put in every baby's bed, and so that everyone gets reminded of it. And we use bundles like prevention of hypothermia bundle, IDH bundle, infection control bundle, CLEPSI bundle, WAP bundle, nutrition bundle, pain prevention bundle, antibiotic stewardship. So each has its own talk, and I don't want to talk much on it, but its importance is really there. And then we have a checklist for cannula insertion, infection control audit, LP, PICC line, aseptic non-touch technique audit, hand hygiene, hand rub procedure, hand wash procedure, housekeeping in NICU, surfactant administration, discharge from NICU, transport within and outside the hospital. Also, there is a checklist. We are not using, in the fluids and nutrition, we do not use betadine or alcohol. We have seen lots of burn in earlier days, and we have like really severe burns with even diluted betadine, so we don't use it anymore. We use 0.5% chlorhexidine. We try to keep our glucose 50 to 150. So sometimes we might have to go to GIR less than 4. We try to keep sodium 140 to 150. And we start acetate because we all know that there is a bicarb loss, and we don't want to end up ourselves giving soda bicarbs. Giving acetate in the TPN has really helped our babies not to develop acidosis. More than 24 weeks, we start full TPN. I start with 3 grams of protein and 2 to 3 grams of lipids within 12 hours. But if the baby is less than 24 weeks, I start protein 3 grams and go up to 4 grams, but I start lipid little slow, 1 and then 1.5 and then 2 and then 2.5, very slowly we go up. And we protect the TPN from photoprotection, because we all know that shielding the parenteral nutrition from light improves survival rate in the premature infant, according to a meta-analysis. We use probiotics from day 1 along with the minimal enteral nutrition. And we all know that most of these babies are born cesarean. They are devoid of the flora which their moms, good flora which their moms would have given them. And we mostly start putting lines in them. We are intubating them. We are giving surfactant to them. We are giving antibiotic to them. So we are actually destroying the good flora, and that's why I feel that probiotics really help if we give early on, and it helps our babies to reduce neck and sepsis on the whole. So skin to skin contact and kangaroo mother care, let me feel the warmth of my mom. That's what the baby says. And as I said, we are going to highlight some of the cultural issues. So we have the issues of cultural issues like curacao because it's from the Pope, and some of the because of the religion here, some of the parents do not like to give Pope a thing. So we do explain that this is not given in the vein, or it's not given to eat. It is going into the lung, and so it doesn't come into the religious issue. And when we explain that, some of the parents do agree, but we have kept a consent form to sign so that we don't go into litigation later on. And another problem is about the kangaroo mother care, because we don't have separate cubicles. So some of the mothers do not like to do kangaroo mother care. So we have put a shield, a big shield, which acts like a cubicle there whenever kangaroo mother care is to be delivered. Then, as I said, we don't have breast milk bank, and donors EVM is not always possible. So these are the cultural hitches and clinches which we all come across, and we try to solve in our own way. As I can say that where there is a will, there is a way, and if we just sit there, we will never be able to go further. And then there is another issue, the insurance issue. We have some DRG thing which has come up, and this is really giving us a very hard time, because what when I talked to the insurance guys, they said, oh, I think they were talking about the thing which came in the newspaper, that only 10 babies are less than 500 grams. So they take it as, that was only 1 unit data, but they have taken as a blanket, and they say only 10 babies are surviving in UAE. So that's why, it's a rarity. And so they have not put any DRG for our babies who are born this small, and there comes the financial issues. And we are trying to solve, because DRG has just come up, and we have a baby who's 23 weeker or 24 weeker in our unit. And let's see how we figure out these financial issues. There are certain agencies where they are helping financially for these babies, and we take help of those societies as well, sometimes charity. So I still say to everybody and to the parents, finance, please look into my eyes, don't let me die. And we will be able to arrange somehow the finances, and let me do the best till I'm there. So I can't lose my baby just because I can't afford to save his life. Then the ethical issues of stopping the life support, and we had earlier that you cannot stop the life support if you have started it. And now we have there are certain amendments into that, and they say that if the parents and the 2 neonatologists, 1 neurologist and the gynecologist and the admin, we all sit together, and then if we really think it cannot work further, we can still not stop the life support, but at least don't do very active measures. Suppose if they have a baby 22, 23 weeker with grade 4 IVH, and parents don't want further things, then we can't take the tube out and allow the baby to die once we have already done our bit. But what we can do is don't do aggressive management. When we combine everybody together, sit together, discuss it out, write it properly, and we have proper forms to it, and fill them up, put in the file, and then see. So the end of the life decisions for extremely low gestational age infants, why simple rules for complicated decisions should be avoided. I believe that. and everybody is moving their boundaries of viability towards 22 weeks. UK, US, Australia, Netherlands, France, Canada. What about us? And Japan is going very fast on that and had already reached to 22 weeks long time back. And when we actually start thinking about it positively, we do start talking of certain measures to be done in these small babies to have a better outcome, and then definitely we will have a better outcome. So I'm sure next guideline from UAE would come as 22 weeks instead of 24 weeks. These are some of my small 22, 20, 23 to 23, 24 week babies who are grown up. These are two twins, pair of twins, and this is a 23 weeker whom I have shown. It's become big now because that was 2016 when he comes, he jumps around in my uh, clinic, and I really feel very happy and proud looking at the baby. So I would end up saying that statistics say I am 1 in 8, but my parents tell me I am 1 in million. Thank you.
Thank you, ma'am. That was a fantastic talk. We're really grateful to have you with us today. We do have quite a few questions, some from our nurses and some from the audience. I've got Dr. Rahmani, who's keen to ask you a question. So I'm going to ask him to unmute himself, please.
Hi, everybody. Hi, Dr. Monika. First of all, thank you very much for this presentation. And I want to commend all the hard work that you're doing to, save those babies. The one thing I'm really impressed with what you're presenting is that you actually find what's the problem that we have when we're dealing with extremely low birth weight infants, in that we kind of approach them as a wholesale. So the most important thing in my mind in the survival of these extremely low birth weight infants are to take care of them in isolated place. So don't mix them with next to a full-term baby and have the neuroprotection bundle apply to all those babies. So I'm really impressed that you already doing this, and this is really the first step. The other things that you're doing is that you're bundling the care. I think we need also to do more and more non-invasive monitoring. Doing blood gases every 6 hours or 4 hours or whatever doesn't really help the babies. Even they start we start giving them more anemia and blood transfusions because we monitor too much. The only thing I'm really not comfortable with what you're presenting is that your GIR rate, which is less than 4. Physiologically, extremely low birth weight infants need about 6 to 8 milligram per kilo per minute to avoid using non-carbohydrates as a source for energy. So unfortunately, I don't think this is possible to keep them less than 4 to keep their sugar up. But I think everything else you're doing is great. And I think hopefully if we all follow what you're doing, then we're going to have a lot more survivals and for those extremely low birth weight infants.
Thank you, Dr. Rahmani. To answer your last query, I'm not saying that we start like that. We do start with the higher glucose, and we all know that when we give TPN, we need to give non-protein energy to utilize the protein to the maximum, and that's what we do. What I said is that sometimes, it's very rare, but I have seen sometimes what happens, whatever we do, the glucose goes very higher, it goes up to 250 and above, and then you need to start, the insulin. And I somehow I'm not very comfortable starting insulin on these babies, and that's the baby where I say sometimes I think I did not elaborate nicely, and that's why that question came in your mind. Sometimes we might have to give GIR of 4 for these kind of babies for some time, instead of starting insulin. But usually this is not what we start with. We start with around 5 to 6 and then monitor sugars. I know there are some units who are doing more and more non-invasive monitoring by nerves and things like that, which unfortunately we don't have that system in place in our unit. Recently I had I was involved in one of the symposium where we were talking about AEG and its use other than just asphyxia. And when I could know that people are using AEG for monitoring of these preemies, and in so much way non-invasively we can monitor, though we have not yet started in our unit using AEG in these preemies. So these small non-invasive, what you said, monitoring might help our babies better than keep on touching them and invasively pricking them. And our unit do not have the policy of 4 to 6 hourly blood gases, or keep on doing the septic workup. We are the least invasive in that way. And when the DRG came, I was very happy that at least this is not going to affect me, at least because I am not doing so many investigations for these small babies. So I remember Dr. Khalil used to cover me from well-care whenever I used to be on leave, and then he used to tell, oh, Dr. Monika said, just be 2 feet away from the baby. So don't go and touch the baby. So that's what I put on a kind of don't touch me. Those are the thing which I showed. That's the thing which we put on our baby so that people are all aware. And clustering is another thing which I didn't talk about. We really do a lot of clustering, and so that the nurse knows that she will, what she has to do, like she has to do the changing, and then she has to give antibiotics, or she has to give the feed and diaper change. All that she will cluster together and then do it. And another thing which we do, and I have not talked because the time limit was there, and I thought we will be talking in our discussion. We involve the parents very early on, and the mothers are free to be in our unit any 24 hours. They are also involved. First they are scared, but later on they are involved even in the diaper change, and some of them later on are even giving the orogastric tube feed and kangaroo mother care, of course, even when the baby is on high flow or CPAP. I'm not that much bold to do a kangaroo mother care with the invasive ventilation. Because of the constraints of we don't have that much of manpower who will and so, but once the baby is on CPAP or NIPPV, we do give that. And even the fathers, though our nurses are very unhappy with me that you are all allowing fathers 24 hours, it's just not good, ma'am, because of the infection and this and that. And now with the COVID, of course, more issues have come up. So with this COVID thing, fathers, we are trying to restrict, but the mothers are still freely allowed. Yeah.
So, Dr. Monika, I just had a question. What is your practice with regards to giving compressions and adrenaline? Do you have a cutoff gestation that in your experience, you use? I mean, would you be happy giving compressions to babies at 22, 23 weeks of gestation? Because that's something that's coming up for debate in the UK at the moment.
Give what?
So using and giving cardiac compressions to babies.
No, that's what I showed you. That's what I showed you. So if the baby is born with very less heart, I don't do it. And I remember Dr. Neil from the UK, I had asked him also, and he was in the same, and I showed you the data that if a baby is compromised and not compromised, especially if it is a smaller baby who is compromised, definitely is not going to make it. And you're just prolonging the misery of the baby as well as the parents, and you're going to give a very bad baby to them, and I don't like doing that.
Sure. There's another question from one of our nurses, and that focuses around obviously the difficulties you have with UAE being so multicultural, in that you have parents with different religious backgrounds, and how do you manage, say, if you have disagreements with parents on religious grounds, how is that managed? How do you take that into account? How difficult is that for you?
Sometimes it becomes very, very difficult, but I would say that if you are, see, whenever, if any baby, if you see, they will be more confident and they will be agreeing to the gynecologist than to you. And the reason is because they are with them for such a long time. And earlier I used to feel very unhappy and angry that, they are quoting gynecologists and they're saying, but later on I realized the best way to go about is involving them with you. And I have taken the help of our gynecologist colleagues multiple times to explain and to understand. And we have sat together even when the babies are born, even after that, to decide on some of the things which we disagree on. And I think that's the way, and then show them the literature. They already are Googling and knowing things which they shouldn't be knowing. And that has made our life much more difficult. And I remember, once when I was in the other hospital, my colleague, I mean, he's very nice. I'm not saying that he. And I was on leave, and it was a 32-weeker, not a big baby. And he, like my unit policy, and because I was chief and I had the unit policy, any baby who was more than 28 weeks, 29 weeks should be full feed on the day one. So it was a 32-weeker, and he had put the baby on full feed on day one. And the baby on developed neck, and he died. And then he became very, very skeptical about it. And for every 32-weeker, he's starting like, how we feed 23, 24, 25-weeker. So, when you sometimes, and this was a debate which was going on even in our AIMS, we have a WhatsApp group of AIMS DM who are together. And the similar, like, and it also depends on which hospital you are in. So if you're in a government setting where, the things are much more divided, and the medical legal issues are much more taken by everybody, then it becomes much more easier to take those bolder steps. And when you are in a private unit where you are the only one and one more person is with you, and you are the one whole and sole responsible for whatever happens to the baby, then sometimes it becomes challenging to take those steps. Somehow I'm a little bit more bolder in that sense. So
No, that's absolutely very admirable. And I think that's what we want to highlight, is that there is such a challenge when you're working in a private healthcare system versus a public healthcare system, which is funded, where decisions have to be made based on what the parents can afford, but also the fact that the parental expectations might be very different. So, I completely recognize and empathize with the difficulties that you have in that setup. And I think for our course and the participants, what I want to highlight is that, unlike in the UK, where we're public health funded for everything. So, when I use a long line and, if it doesn't go in, it gets thrown away, uh, I get a fresh long line. Or similarly, when I'm using nitric and I'm using it, I'm not looking at it by the minute. But if we look at the costs, uh, that would be passed on to parents in circumstances like that, in setups like yours. That is something that is really challenging and something that we don't have to deal with. So, my compliments on that. There's one more question by one of our participants, and that really talks about redirection of care. So, in your experience, do you find anything that we should be doing differently for cultural? So, say, for example, if we have parents from a Muslim background versus parents from India, what aspects of culture do you think we can learn that we might be doing differently in our practice around, say, discussions around comfort care with those parents? What aspects of culture are important?
I think I highlighted on a few of them, like one is the CuroServe. So when the CuroServe was, first of all, it took a long time for CuroServe to be allowed in the country, approval. And then I remember Dr. Ramanathan had come over and we had a big first seminar many years back, where all the neonatologists from the UAE were together, and I think Dr. Rahmani was there also. And then this debate was there whether we should be using Eurosurf because of the cultural issues, whether really it is of that benefit that you know. And there were a division between the neonatologists to say that when Savanta is not doing that bad job, why should you go for a Eurosurf, which is and then there was a debate, and Dr. Hisham, I remember he had shown that there was not much difference if you are using Eurosurf. So, you know, those kind of issues are there. And now, you know, when we were doing this EEG, AEG thing, then there were a talk on like when you are actually, and I don't know, it may come up in some time when you are actually giving a Curacao, which is actually causing rapid change in the compliance, and would be a change in the blood flow as well, which that will also be getting affected, and the brain with that rapid change might get adversely affected. So what we you know, we go to square one when we start and do something, and then we see, oh, there is a harm, like how with the oxygen. We started giving 100%, then there were ROP, then we went to 21%, then there were deaths. So, you know, so we are still learning, I would say that. So, but there are cultural issues of this Eurosurf, and as I said, what we do is that we do have a consent form for it. And I always try to involve Arabic person to explain, the registrar who's Arabic, so that it should not come that when I'm explaining, it is like, you know, religiously I'm not biased to give them, because, you know, I can take them to certain decisions, you know, the way I'm talking to them. So it should not come in the end that I'm taking to them biased decision making. So that someone who is also in the same cultural and religious issue is talking to them, and then they take a very open-minded answer. And second is about, as I said, kangaroo mother care is another issue because we have an open unit. So we try to put a shield, a big shield, and try not the fathers are not allowed during that time when the kangaroo mother care is going on inside, even if it is in one corner. And then the breast milk is another issue because we don't have the bank, and it is a big issue. So we try the mothers. Immediately we try. I talk to them and talk about the breast milk. And recently, it's not in a problem. Not only a problem of a preterm, we have a problem with the term babies of exclusive breastfeeding here. And it's very difficult time for me to explain that, and you know, because many people are involved. Gynecologists is involved, they are going to listen more than me. And so we have a recent paper. It's going to be, I think, published on the increasing the breastfeeding rates here. And so you have to design your own ways and means to improve those. So it's always, we take something from the West, we take from the evidence, but I say it is science plus the art which will make your success. So we have to see your own unit and, you know, design things according to them.
Completely. I'd like to take this opportunity to thank you for speaking to us today about how you would manage babies at limits of viability in the UAE. I'm really grateful. It's been really enlightening. And I would also like to thank all the participants for joining us. Obviously, from our perspective, what we would aim to do is continue with our series of talks on neonatal ethics and perinatal epidemiology at the preterm limits of viability. The next talk will be on Monday and will involve Dr. Martin Zasser, who will be giving us a perspective of defining limits of viability from a developing country perspective, speaking specifically about his research study in Nigeria. So please do join us for that. But thank you, ma'am. I'm so grateful. God bless you. God bless you all.